The next session is on wall verify and the international.
Welcome everybody to our next didactic session, and I've got a short kind of orientation, filling folks in on what we've done, but I really wanted to pivot quickly to more of a conversation between the folks that are up here. Sorry. So what we're talking about this morning is a project that, as you may surmise from the ongoing theme, is a public-private academic partnership, and another success story that we wanted to share, because I think it's a model for not just how other projects can be doing, but I think it's a model that it itself can be expanded to meet a growing need to engage with the public. And as another evidence of what Dr. Shaw referred to as our three pillars of equity, innovation, and engagement. So smart health cards and smart health links, and the instantiation of that in Washington, which is Wall Verify, and I'll go on to describe Wall Verify Plus. Next slide, please. Our panelists that I'll introduce, myself, you've heard from me a couple of times. I'm the Chief Medical Informatics Officer for Washington State Department of Health. I'd like to introduce Dr. Bill Lober, who's a professor in global health at the University of Washington. Been very active and a colleague of mine for years. In fact, he was on the interview committee when I first applied to join the University of Washington, and has been a colleague and collaborator on this project and many others. Dr. Brian Anderson, a fast friend. I think that the 3 years that we've known each other during COVID feels like 7 years, but it's a good thing. We just got 7 years worth of work done in the last 3 years. Who's the Chief Digital Health Officer for MITRE Corporation. And Geraldine, this is awkward. You should sit in the middle. No one puts baby in the corner. There, that's better. All right. Geraldine Miller, who I've had the honor and pleasure of working with, and has had several different roles at Microsoft and Microsoft Research, I think all of which have been poignant in building upon an ability to be an amazing partner with state health departments. So thank you, Geraldine. Next slide. So, quick and brief overview. How many people know what WA Verify is? Wow, okay, so my talk is done. Let's move on to the discussion. It's, for those of you who from out of state, and WA Verify allowed Washingtonians to pull their COVID vaccine data onto their phones. And it was using a technology that was promoted by the VCI Coalition, of which Brian is the chair or cat herder of. And recently, Washington State, myself and Les Becker were invited to join the steering committee of VCI. That innovation allowed us to make those digital QR codes available to folks in Washington. It was a capability that in 2021 we didn't have. We were relying on the paper CDC cards for people proving their vaccine status. And we were starting to get phone calls from people who had lost their cards, and and then our governor and our local jurisdiction was moving towards making mandatory proof of vaccine for entering large venues or restaurants. And we needed a solution, and we needed it quickly. So we turned to our colleagues at VCI, and is Sheridan in the audience? There's Sheridan right here. So Sheridan actually, we met in Portland for the first time at an Immunization Registry Association meeting. And and Mary Beth, is Mary Beth in the, there's Mary Beth, we should have had Mary Beth on the panel too. Yeah, so Mary Beth for the American Immunization Registry Association. I encourage you all to chat with her. The story began with how quickly could we get this ready, because our governor wants it now. And we, as you can see, in 8 weeks went from concept to launch. You know, I've never in my life participated in a government project that launched in 8 weeks. And it's really thanks to the partnerships, that public, private, and academic teamwork. As Janet said, you know, including weekends. Daniel Lorgan, I got a special thanks to you. We were having trouble getting code, and actually, and Brian, you had some coders at MITRE Corporation. We're having trouble. We're going to have to push back our launch date. And October 25th was the day that the governor's mandate for vaccine proof to enter large venues went into effect. And we were going to have to push back the launch date because the coding was taking longer than we thought. And between MITRE Corporation and the University of Washington, working, handing off code to each other, East Coast and West Coast, over a weekend, when we came back Monday morning, the code in the GitHub repository was finished and ready to push into testing. That kind of teamwork, sharing resources, working together, using tools that you could build off of was fabulous. And another big thanks to MITRE. We'll cover this a little bit in the discussion. A big chunk of the code had been released and shared on GitHub by California, our colleagues in California, but our health department, and you know, don't bash them for this, was a little bit distrusting of open code. To get to a confidence of implementation, we asked MITRE to do a code review, and as an unbiased experts, they reviewed the California code and gave it a seal of approval. There's nothing nefarious, no secret backdoors. This is okay to use. Really helped us get to that launch. But the real success story here is not that time or that process, the collaboration. It's that over nearly 2 million, we haven't quite crossed over the 2 million mark, people have leveraged that, pulled this asset, this resource down onto their phone. And now, and we'll go on and to talk about how we want to build off of that success story. Next slide. It is a multi-state collaboration. So as I said, we based it off of California code, but then we quickly built a West Coast coalition of Alaska, Oregon, Washington, California, even Idaho. Where's Kathy Turner? Idaho was able to participate through one of their private sector partners. And is Docket in the room? If Docket could raise their hand. So private sector partner Docket was able to add this capability in Idaho. So we really have grown this capability by sharing this knowledge, sharing the code, sharing what's successful. So big thanks to everybody here. And all right, next slide. So we didn't want to leave anybody behind. So I think one of the biggest tenets, and you can see 47 different languages. 47 languages. Providing this information, providing access to this really is something that we're excited. We did not leave anybody behind, and the device, the application auto-detects the preferred language of the individual on their smart device, and they don't have to struggle to find this drop-down menu. It automatically displays in their preferred language. So, next slide. We demoed this at HIMSS, and I think Jen Layden was super excited about this when she saw it, and she's like, we need to tell other states about this. Like, other states are already hearing about this, but yes, let's tell more. This is an amazing capability. And again, we don't want it just to be people who can afford smartphones, although 80 to 90% of our population do now have smartphones. That's bringing a big piece of the population along. We also want to make it available with an alternative of printing it on a solid card. And I've got, you can't see it from where you are, but please come up during the break and I'll show you what the actual cards look like. Next slide, please. So we want to move on beyond this and talk about WA Verify Plus and a demonstration we've done with the Office of the National Coordinator for Health IT for incorporating international patient summary. So instead of just your COVID vaccine information, being able to include your entire vaccine record, medications that you're currently on, your list of current problems, the complete immunization, as I said, and then any relevant positive or negative test results you might need for entering a country, and any recent medical procedures you might need to document. Next slide. And this is what the WA Verify system looks like, and we'll talk about this in a little bit more in a bit. Next slide. And next slide. Oh, go back one. Okay. All right, so what, Geraldine, what do you think is exciting about smart health links versus smart health cards?
Right, let me share a little bit about my perspective. It's not going to be a technical perspective, which will surprise you. So what I think is exciting about smart health links is that it enables scenarios like international patient summary. I had the pleasure of speaking to an individual at BRAC, which is a very large nonprofit that does worldwide outreach, who was also a practicing physician in Bellevue Hospital in New York City, one of the oldest public hospitals in New York City. And he shared with me some of his challenges about being an emergency room physician and having a person show up at his hospital, sometimes not even conscious, no information on them, and having to treat just this person, this body that's there, right? No context of chronic health conditions, no context of allergies. And we started talking about international patient summary and how if you could have just a summary of information that was on the one thing the person might have on them, right? Their smart device in a developed country, or their wallet with a card, how that could radically change the ability to quickly deliver care. So I'm excited about smart health links as a technology to enable additional use cases. We saw with the with smart health cards during the pandemic how this could really enable a number of scenarios. I love to, Sheridan made a comment to me, she's like, you know, smart health cards and what happened in COVID was like this wonderful beta testing or proof of concept for the technology. So we know the tech works, we can expand the tech, and we do this through standards, and I think we'll have an opportunity to talk a little more about the standard side later.
Yeah, so standards, I think, this is something that I actually need to chime in with Miter some more. Brian, could you talk a little bit about VCI's mission around that standards development process?
Yeah, so when we started VCI, obviously the initial use case was the COVID vaccination and the verification steps that many of the states were rolling out then. As Geraldine is alluding to, with Smart Health Links, there's this incredible opportunity to leverage some of those initial standards that we focused on in vaccination and testing to broaden that to other areas that ONC has, been pushing on for a number of years, the U.S. Common Data Elements for Interoperability, or USCDI. And I think one of the exciting spaces that we're very interested in going in and partnering with you and WildVerify Plus and other states is, those core set of data elements that go into USCDI. How can we take a standards-driven approach and roll out smart health cards, smart health links for those other components of the core data sets that are, from a regulatory standpoint, required to be part of your health record? And you can just imagine all of the other use cases that are made possible with something like that. And that all starts with that standards implementation guide process that, I'm so lucky to have you as a partner in that, Brian, because you keep me honest on all the HL7 working groups and make sure we get through ballot and reconcile all those negative comments.
Thank you. Thanks for that. He's joking a little bit because we're
Just a little joke.
The public health working group is getting a little bit of a ding because the ballot process is taking us longer than the other working groups in HL7. I keep telling them, well, we have been dealing with this little event for the past 3 years that's kept us busy. Can you give us some grace? But our metrics are not looking good. We'll get better at it. So. Bill, I think from an HL7 standards process, you've been in all these public health work group meetings. You have staff that participate on your clinical informatics research team. You talk a little bit about how ready for a release for trial use were these Smart Health Links standards, and how much work do we have before it becomes a full production system?
I think that there are a lot of areas to explore around. I think I'm on. Okay. Yeah, it sounds like a little reverb from up here, actually. But yeah, good. I think that there are a lot of interesting areas to explore around the use of Smart Health Links. But I think that the barriers aren't, or those areas are mostly kind of organizational and workflow rather than technical. I would agree with Geraldine that the technical foundation is pretty solid. The way I think of Smart Health Links is it's a way for people to share verifiable clinical information. The reverb up here keeps changing, so I apologize if it's that way out there too. Yeah, there we go. Now I'm loud. Now I'm not so loud. Good. Anyway, so I see Smart Health Links as a way to share verifiable clinical information, for people to share verifiable clinical information. And that raises two kind of interesting points. One is, who's doing that sharing? And the second is, what are they sharing? So in terms of who's doing that sharing, what's exciting to me about Smart Health Links, about the use of Smart Health Links to share information like the international patient summary information, is that we talk a lot about the value of patient-centered care and about moving to ways to to engage patients more directly in their own care, in decision-making about their own care. And part of that is to be able to control the sharing of your information, to be able to provide new methods, new channels, to be able to share information with both providers, as I think it's interesting, Geraldine talked about a conversation with an ED doc. I was interested to discover that Ann Zink from Alaska was a former ED physician. I'm a former current ED physician, I'm sorry, Ann. I'm a former ED physician. And a lot of people in emergency medicine are particularly tuned into this idea of practicing in the absence of complete sets of information. So that's why you see a lot of us in the informatics space, I think. But so who gets to share information? I'm excited about the fact that Smart Health Links enables patient-centered care through patient-controlled sharing of information. I'm also very interested in the kind of information that they share. Smart Health Links is links to information, and both of those terms are interesting. The links themselves are controllable, they're authenticatable optionally, they're password protected optionally, they're time limited optionally, all kinds of like novel things that people haven't been able to do in the past with their elective voluntary information sharing. The information that they share is interesting. We started out with smart health cards, which encapsulate the content of the information into the QR code. And as Brian, I think, alluded to, there's a pretty specific limit to that in the amount of information we can share. Smart Health Links allow us to use that same structure, but to provide a link to information. And that information can be either static, it can be the medical summary that I created last spring, or it can be dynamic. It can be a information gathered by a server and shared on demand. So fantastic potential. The technology is very solid. For me, the interesting questions are around use, adoption, the different roles that different stakeholders, including public health, might play as the system evolves. So I don't know if that answered your question, but I'm less concerned about what the HL7 working group does.
Can we get 2 million users in 8 weeks? Probably not quite there yet.
Not quite there yet, but can we create a compelling value proposition for people like us? And what role does public health play in that value proposition? I think those are interesting questions.
So, Del, is there anything we need to do about the audio? Just a quick check. Yeah, so we can get closer to the microphones, guys. There, thank you. Perfect. All right, so diving into the end user trust. I think that, and this I should have had Janet stay on stage with me, but as we were rolling out WA Verify, one of the things we did is we wanted to get feedback, user-centered design feedback on how it was working, and feedback from the communities, especially the communities that we wanted to hear from both the people who were engaged and the people who didn't trust it or like it. And I think there's some really interesting opportunities. Just the COVID vaccine had its own set of issues and complexity, but I think moving ahead, seeing that a complete use case, seeing a use case that has more to do with a non-controversial subject helps us engage with more people. What are your guys' thoughts on that? That complete set of things that could be carried in a smart health card. What's most likely to come along and be the magic attractor? Is it the complete immunization record? Is it the use of a mini medical record for those emergency room visits? Or is it something that we haven't had yet, like a ability to carry your advance directive around with you that maybe has your do not resuscitate orders, or what your wishes were if you were in a mental status that made you unable to express your wishes, or maybe expressing the wrong wishes. Or something even more trivial, like we all have insurance cards, why not have a digital insurance card that changes with your benefit changes instead of having to remember which one is current in your wallet?
I think, we talked about this a little bit, and we're trying to develop sort of a cascading series of use cases. So this is not completely thought out. But I think at one level, we think about the kind of information that people had to present during COVID for border crossings. So testing and focused vaccinations. At another level, we can start to add the traveler health profile, the things that people might want to add to that, like required and optional travel vaccinations, prophylaxis that they're on, so forth. The next level is probably urgent and emergent care. So what do I want somebody to know about me in an emergency? What am I willing to share about myself in an emergency? The next level, and I'm going to kind of skip insurance because I think you guys may know, may also, yeah. Anyway, so what do I want somebody to know about me in an emergency? The next level up is probably the kind of thinking about portable medical records. We didn't really talk about this explicitly, but the standards that underlie both smart health cards and smart health links, my guess is everybody in the room knows this, but the standard that underlies that is FHIR. So the data that are provided through those mechanisms are fundamentally more exchangeable than other types of data that we've been able, other types of health data that we've been able to kind of present in the past. So, so that's a good thing. Remember, this is all sort of part of the FHIR ecosystem, and I don't think we said that explicitly. But so that next level is probably the kind of portable medical record that Geraldine alluded to. Wouldn't it be great if I knew? And then, Bryant mentioned advanced directives. So there are required components of the IPS, and there are some optional components of the IPS. And one of the optional components is advanced directives, but we've thought about that as like the tip of the iceberg around expressing patient preferences around mental health treatment, patient preferences around controlled substance contracts, patient preferences that they would like providers to be able to act on as part of their record. That's not stuff that is well organized in the current medical record, but it's an area where HL7 is actively involved in developing a set of standards and implementation guides. And it's an area that we're actively interested in folding into the patient's controllable, shareable information. But I think keep that hierarchy in mind. Little information, more. And that speaks to the need for different levels of summarization that a patient might want to share. Please.
All right. So let me share with you something in technology that we call the process of evangelism, and thank you for the mic. You typically, when you want a group to adopt or a technology, you need to establish what's a beachhead, right? A place where you can land the technology. When I think of smart health cards, if we all see value in this, right, we need to find a way to bring this to ubiquity, right? And ubiquity has to be across time, right? So not a moment in time, but across time. And so I offer that we really think about what is that scenario that will drive the concept to ubiquity, and then you can land the kind of cascading series, as you were talking, like almost like the concentric rings, right? So I would offer maybe that's health insurance or some type of digital insurance card, right? In my mind, I always think about what is that one thing you might not travel without, you might not go without, right? For many people, like the delivery to mobile device is strong. The mobile device is probably the one device that you would go back to. So we have the mechanism to land it, but what is the specific scenario that we could land and then extend from? I also do want to call out, you made a comment earlier before we started talking a little bit about the, kind of the scenarios about the value of partnerships, and I just want to hone in on that really quickly. We saw this through the pandemic, right? The value of public-private academic partnerships, and I want to add one element to that in public health, and that is community. I heard a mention of the fact that, we did user testing with people, and we need to keep the lens or the context that we're building this not for ourselves, but for a community of people. So we need to be inclusive and bring the community along as well. And so that multifaceted partnership concept is the way that we could land something like this. And so we all have to commit to that, to keeping the investment going. And I think we'll talk about that hopefully in a little bit.
Thanks so much for sharing that, Geraldine. I was going to bring up community as well as one of the other additional words, Janet, to trust. I think having an active voice and engagement in that relationship from community members, the end users, I think really is a good forcing mechanism to understand what their use cases are that matter, that get to that kind of adoption that you're talking about, Bill. So completely agree with the beachhead analogy. When we think about the workflow of an individual coming into an urgent care or to a doctor's office, it oftentimes starts with an insurance card. And so I would agree. I think that from an adoption standpoint, outside of COVID, one of the most important specific uses of smart health cards and links is the insurance card, because it's usually that first thing that the medical assistant asks when you step up to the desk. You know, can you show me your insurance card? And oftentimes there's fat-fingered, fat-thumbing of numbers, and so sometimes there's denial of claim adjudication process in that if it's not entered accurately. The other thing I think that we didn't talk about, so I mean, what's the next step that happens? You fill out one of those 2-page, 5-page forms that you filled out a dozen times, your medical history. How many times have I documented I'm in good health, and so it's always no to all of those things, but I check the box on all of them, and it takes time and it takes effort, and I repeat it ad nauseum every time I go into the office. Why? Is there a space for a smart health link to help in that? We've had some conversations with various government officials, and we've settled on this term called QR to the max that I think you might be hearing more about soon. But if you think about QR to the max and what that means, QR plus to the max. There you go. I think it starts with insurance cards. I think it then, you look at kind of the use case and the usability of the QR code in a situation where you have these forms you need to fill out. Gosh, wouldn't it be easier? Scan my QR code. Here's my medical history stuff, so I don't have to fill out this silly form.
Can I make a comment as a data scientist? Okay, so part of what I do is I do Health AI at Microsoft. I would also offer that perhaps self-reported information isn't as accurate as a medical record, right? And so it might be interesting to actually have an accurate perspective of it versus what somebody is relaying to you. From memory.
That opens up a whole new basket of how Luke and I were just talking about this earlier. Does an EHR vendor or the health system trust patient-reported over a doctor's medical history? Fascinating conversation we could have on that.
Right. And so I think there's an interesting intersection between the ownership and verification of information and the information that a patient chooses to share. If I was required to state my verified HIV status as part of my travel profile, I might be reluctant to travel to certain countries if I was positive, right? So in the end, there's this notion of some kinds of information which we know to be true because it comes from a state immunization registry. Some kind of information that we, as the state, might think is true because it comes from a healthcare provider. But we don't really know that the healthcare provider's got correct data in their EHR. And some kind of data that we don't really know if it's true or not, an advanced directive, for instance, that's really the patient's authored information. And so, how does that, this is like another one of those big unanswered questions, I think, is how do we kind of live in this world where different kinds of information have different kinds of provenance and yet still are we still willing to serve as a custodian for that information independent from being a guarantor of its accuracy? The tradition is, anyway, I know Brian is anxious. By the way, I know Brian is anxious to actually show some stuff that's real. I noticed when he first put up the QR code, I could only sort of look in that part of the audience, but I noticed that Sheridan was the one who wickedly whipped out her phone to check the QR code.
I'm so glad that you're doing this.
Yes.
It's actually
And you'll notice that I also checked the QR code.
So we wanted to leave with a call to action of, what can we do to advance this standard? And So everybody pull out your phone, scan this QR code. It takes you to a sample patient. So pretend you're that emergency room physician. Pretend you're in another country, and there's a patient who doesn't speak your language. You're able to scan this QR code and get a summary of critical information you need to know about them. And as you can see, you didn't have to install any special software on your phone. It just works. And somebody please confirm that it worked.
It does. And quickly.
And so to that, a couple of my engineers are here, and Ivan and Daniel get credit for that.
So I think that, seeing a concrete example of how this could work, something tangible. We did a demonstration of this for the GDHP in collaboration with ONC, who's the current co-chair of, and we had these cards printed out for Maria, passed them out to other countries that were members of the GDHP to use, and we couldn't get any of the cards back. They became like these,
Trading cards.
an amazing souvenir from their visit to the in-person event. So, so Maria, who's a totally fictitious patient, we're not doing any HIPAA violations here. She's now got a card floating around in 25 different countries around the world. But I think we've got lots of interest in advancing this standard, making it more interoperable, continuing to work with other states in our Pacific Northwest region, making this a capability. The call to action is that it doesn't have to be international travel, although the standard is IPS. I think it has a huge use when you travel from state to state, or just even out of your home neighborhood where your doctors know you. So, all right, do we have time for a few questions? Great. All right, there's a microphone right there. Raise your hand. I think this QR code goes to the same place.
Well, I'll just make a comment and then pass it off for other questions, which is you now all have access to the International Patient Summary demo. If you'd like to see a demo of a Smart Health Link working with a complete immunization record, Joe, who Bryant called out at the beginning, he can show that to folks either here or in the future. And similarly, if you'd like to see a demo of a digital insurance card, which you heard both Geraldine and Bill and Brian talking about as sort of, maybe that leads us to ubiquity. Brian and the VCI Coalition can give you a demo of that.
Hi, thank you for the great presentation. Scott David, University of Washington Applied Physics Lab. I wonder, during the 1940s, they had the Uniform Commercial Code, which was part of the way of greasing commerce among the states, because, Wisconsin had proprietary dairy laws, things like that. Has there been any activity to try to craft some uniform laws that might be adopted for the states, so then effectively making these or some subset of these metrics and these approaches uniform on a regulatory basis among the states because of our challenge in our federal system that might be a vehicle, an extra legal vehicle to having legal interoperability that clears the way for some of the technology which is already interoperable to be used.
Yeah. Brian, I'm wondering if you could talk a little bit about the efforts MITRE did with the WHO and...
Yeah, so 1940s before my time, but...
MITRE did exist back then.
I think we might have, yeah. So we're doing a lot of work, both I would say at an international and at a federal level. So I'll start, I guess, at the federal level. When we think about interoperability between states, I would say, a lot of the work centers on working with the electronic health record vendors and the immunization registries that work closely with state public health agencies. ONC is the main regulator of those types of technologies and that kind of interoperability. And I'd mentioned this QR to the max thing somewhat jokingly, but I think there's a real seriousness behind that. There is, I don't want to get ahead of myself and say, I think there are plans for it, but I think there's a real opportunity and potential for an organization like ONC to say, yes, these kinds of QR codes, this kind of standard that are already building upon US CDI is the path to that, that greasing the wheels of data interoperability and portability, individual empowerment with their own health records. I think that's one thing. At international level, Bryant mentioned the work with the Global Digital Health Partnership. We're also working closely with the World Health Organization and the Organization for Economic Cooperation and Development, OECD, and they're very excited about what smart health cards mean at an international level. There are some other competing standards, right? We're still in the VHS versus beta, world of 1970s right now, just to be honest. But if you look at, I think the convergence, my hope is that we align on a standard that is easily usable and understandable and portable and trustworthy, and I believe that's smart health cards. We're not there yet, just to be, transparent, but I think there's real opportunity at the international level with the WHO and the OECD.
It might also be an opportunity to convene with the National Conference of Uniform State Laws and to invite the insurance companies in there as well, because then there's a benefit from the industry side and from the public health side as well. So, and NCUSL is where they naturally do some of the work on uniform state laws. And again, it's just an offering to the legislators, but it might be another pathway.
Scott, what's the acronym again?
Oh, National Conference for Uniform State Laws, NCUSL. They do work with like secured lenders and just trying to find national
Akuzal's
laws.
just a fun word to say, akuzal.
I love it.
I think the other thing that I would say, though, at the federal level, from a rulemaking perspective, the rules around meaningful use or the kind of precedent for requiring certain types of information exchange, and then the 21st Century Cures Act is the sort of specifies both information content and standards, and that is the basis for the kind of iterative process that that is described in kind of refining US CDI plus. So I think there is like regulatory foundation or rulemaking foundation.
I also want to make one comment. This goes to the comment of establishing a footprint, right, or a beachhead. If we do this here within the United States, we can also set an example. There are entities as well, like the UN IGF, Internet Governance Forum, who are very interested in transformation at an international level, especially digital transformation. So there are other avenues to drive this, but I would offer we start here within this room by committing.
Yeah, if we've got time for one more question?
Can people hear me?
Oh, we have 50, excellent.
So I'm very on board with doing something like this, and I was curious, like, on the medical provider side of things, like, what are they still hesitant about? And is it mostly just something where, like, there hasn't been enough development for it to be something that they trust, or is it just something where there's, like, very few incentives and they're just not interested in engaging in something like this until, like, an outside organization sort of forces their hand?
Yeah, I think that it is a little bit of a catch-22. The private sector is not going to move on a new technology till there's a demand for the new technology. But the new technology is not going to be demanded unless people know that it exists and is possible. So there's this conundrum. I think that Verify, at least for 2 million folks in the state of Washington and hundreds of millions of people across the globe, half a billion. Okay, yeah, that's a pretty good threshold. We're able to utilize QR codes. And I think the pandemic as a whole has opened up the use of QR codes and an expectation of easy access to information you need on demand. So people are now going to expect that they can carry their critical information around with them on a smartphone. We've done a giant beta test, as has been said, that this works. And between the Apple Health app on the Apple side and the Google Wallet, I think there's going to be mechanisms that people expect to be able to carry this information around with them. And Smart Health Links is a easy mechanism for us to do that. I do think that there are some competing standards, the Betamax versus VHS, and we need to keep demonstrating how this works and how the use of FHIR and a fundamental underlying consistent standard is the best path to go as opposed to a proprietary approach. I was gonna make one mention in that demonstration. It's like Brian, myself, and Dr. Shaw got invited to accompany the US government and ONC on a trip to Spain to demonstrate to the EU and the global G20 how this kind of a standard could be used in a way that it helps to keep economies open in future pandemics so that we don't have to do these shutdowns again, or can limit the shutdowns to people who don't have proper documentation of being properly protected. We need to get those things out ahead. We need to prove out them during the blue sky time so we're not developing them in the panic. I don't know, what are your thoughts on?
Go ahead, Bill, you first.
Oh, I think Ryan and I both have comments, but I wanted to, the way your question was framed, I feel like I need to put in a good word for the medical providers. And that is that medical providers aren't the decision makers in anything other than what do I do in the next 15 minutes. Healthcare organizations aren't the decision makers in how how aggressively vendors choose to implement different standards and features. There has to be both a regulatory driver, which I think we have, and our federal partners are doing a really good job both setting a stage with digital modernization and with the regulatory framework to support that. And there has to be, just to return to what Geraldine said, and we all enthusiastically agreed with, there has to be like a compelling use. There has to be a beachhead. There has to be either information that people are required to share. In COVID, that was obvious. With insurance, that's part of the way we get healthcare. Or there has to be information that people are really compelled to share. And we kind of are looking for both use cases. Ryan.
So a little bit of a different slice of it. So providers, I don't think, are the problem. I think just as Bill is describing, I think they would readily be willing to accept that information. When you think about the current ecosystem of health systems, they're incentivized to keep their patients, relatively locked into their network. And so if you think about, well, here's a path to empowering individuals to take their health record, to take their care wherever they, choose to go to, you're swimming upstream against some really powerful equities that would say, no, we want you to stay here. And so the health systems, I don't think they're advocating as much for this as they would want to. Maybe, some of the urgent cares and pharmacy chains might be, but some of the big health systems, probably not, because they want their patients to stay where they're at. And I would say because of that, the technology vendors haven't gotten the message as strongly, like, yeah, we want to, trust that record, to scan it, to take it in, and now, we're going to go through a reconciliation process of that record to, whatever record I may have. That's for any clinician out there or a medical, provider, that reconciliation thing is a hard, messy thing to do. It takes time, and the workflow is challenging. And so technology vendors, I would say, haven't gotten the message. My perspective, transparently, is that I don't think health systems are advocating for it as much as they could. I do think that there's an advocacy part of it that goes into working with the federal government to advocate for that kind of thing. When we talk about, I love ONC, I'm a big fan of ONC, but when you look at TEFCA, the use cases that TEFCA contemplates initially right now patient access and patient pushing and pulling of data in TEFCA, that's not a use case that's contemplated right now, right out of the gate. And so what can we be doing in this room to advocating for those kinds of individual patient empowerment use cases to enable, I think, what you're describing?
My name is Jane Nassif, Public Health Agency of Canada, or the CDC of Canada. So first and foremost, my hat's off to all of you. Way to go, Washington. Like, this is, it's so awesome to see. And as you're speaking, I'm madly texting some of my colleagues back in Ottawa. So you'll be getting a call from us soon. But I wanted to ask, we are in, I'll speak for Canada here, we have many silos still. And we have many systems that still simply just don't talk to each other. And this is a fantastic example that shows that all of the barriers can be broken. And I'll speak as a mother who has twins who are going into school. We are required to report their vaccines for our children so that they don't get suspended from school. But as that mother, I had to actually physically take, we call it a yellow card back home, and enter it into my local public health facility. And that would then go to my provincial, and then so on and so forth. So are you at such an advanced position that this information is actually from the medical provider? I know we had some conversation that you mentioned about patient-reported versus provider-reported. So is it that far along that all of your systems, even down to primary care, are reported upwards?
So one of the great things about fire bundles, or the fire standard, is that meta information about provenance, like where that information was collected from or documented or verified, can accompany each of those pieces of information. And what can be displayed on a simple web page and what's displayed on the web interface when you're looking at it, there's more detailed information in the full JSON bundles hidden in each of those elements, so that there could be that documentation. And then it's a heck of a lot better proof that that's really the vaccine they got than parents typing in their vaccines into a web portal. You know, there's that authenticity comes along. We spent a lot of time in the VCI coalition coming up with a way to digitally create that authentic signature embedded in these QR codes so that you can't fake it. A lot of people are like, oh, I'll just use such and such as QR code, and you can't, unlike the QR codes that you make where you can like make your own, without the proper credentials, you can't spoof this.
One of the challenges I think that we have here in the States is the, siloed, federated, whatever, broken in terms of how the different states work. So there are mandated, required vaccinations that are required to be reported up into an immunization registry for each state, coming from a PCP. There's, as I understand it, not a common set of mandates or requirements for those records to be sent back down to the primary care's physician. And so one of the challenges we had in VCI was, well, who's signing the card? Is it the immunization registry or is it the PCP's office? Who actually put the jab in the arm, and can they sign that, or is it coming from the state? So it's not a clear standard in terms of a process standard, and it's still a challenge today here outside of COVID in terms of who has the record, who's signing the code, or excuse me, the smart health card. But that's something I think we're trying to work on. The ideal would be that a PCP could sign and issue a smart health card. A registry could sign and issue a smart health card. And ideally, a patient, if they want to generate their own health record or outcomes or symptoms, could also potentially sign one as well.
But that provenance would be documented.
Yes.
in the link, in the details of the record.
Yeah.
I want to comment on quickly just on the comment about data silos and interoperability. And we're not all buttoned up here across the board either. We're getting there, right? But it is a challenge, right? And standards are a challenge. And even if there's a standard out there, implementation of a standard takes resources. It takes resources on the standard committees and bodies. I know, like internally to Microsoft, we have dedicated resources. One of our individuals, Josh Mandel, and I do understand that Smart Health Links was kind of like his, brain side, his insight, his brainchild. Those are real resources who they get up every day and they're committed to the standards bodies, right? And to the work, Smart Health Links, Smart Health Cards, and then Smart on Fire. And so it does require a commitment in terms of actual resources. And that's at multiple levels. That's just not from a tech company standpoint. That's from an implementer standpoint, anybody who is working on standards or policy and things like that. So we can't lose sight of the fact that this stuff doesn't happen without investment in terms of, people capital. So.
I wanted to make a couple of quick comments about,
Yeah.
yeah, although, okay, fair enough. The one thing I would say that I have to say is that there's a link on here for the home page of the Smart Health Links system that we've implemented. And what that system does is take a pre-existing international patient summary or one that you can identify yourself and create a QR code so you can experiment with the password, with the time-limited links and so forth. I have to use hands for this, but the other half of the equation is how you create that IPS in the first place. And that's, I think, part of your question. And we're sort of piggybacking on the 21st Century CARES Act legislation, which requires that vendors give patient electronic access to their health information. So I won't go into more detail than that, but this is like an area that lots of people think about is how do you give people the ability to access their information and then appropriately package those summaries. So your kid's vaccination record should be something that you can put together electronically as soon as they get those shots, basically, or that's available to you.
So apparently I am the last question asker, so I will, in case anyone's curious. I'm Luke, I'm from Apple, and so my perspective is very much on the individual viewing their own record rather than on the system aggregating these things. But from what I understand of what you've been talking about, this particular link is very much these are the things that I need to be able to share when I cannot do it myself, and I get a nice summary. But then, as you have mentioned, the US system is very fractured. One of the things that I would be what would be great is if I could log into my own medical record from the various providers I have and have those, I'm just gonna say, come onto my iPhone, because that's where I live. And then have Washington have access to those on-device medical records through an app that you guys have run so that you can run an update onto the record that you have for me so that I can say, oh, I have a new prescription that should be available. I need to be able to share that back to you so that when somebody accesses this link, they get that information. And so that you make a dynamic system that can be updated as as I get the new vaccination from whoever my provider is, it comes back down to my device, and that device is able to give me the power to share it up to you so that that can be displayed. And I'm wondering, have you thought about that? Are you implementing it? Go.
I'll let Bill briefly answer. I think of it, we talked about provenance and being able to document where the information came from, but curation, I think having the patient be able to make choices about, because they know where their information is, but they want to pull it all into one place. And being able to, I had so many people that, everybody's moving to Washington from elsewhere, and they're like, oh, my first 2 COVID doses are back in California. How can I get those into my record? we need a mechanism where they can reach out, pull that information forward, and bundle it together. And Bill, do you want to talk about the MyChart integration you've been
Yeah, I mean,
piloting?
The simplest answer is we have that app. So we've built that app to run against the EHR Fire endpoint. Apple Health should expose a Fire endpoint using the same standards. I think Apple's Health uses Fire internally, so.
You have a Fire endpoint, a login, and a password.
Right. So Apple Health lets you import from an external Fire endpoint, but for Apple Health to fit into that ecosystem, it also needs to expose a Fire endpoint. And I don't think that's a big stretch because of the way you guys organize that information. So we have the app that takes that reads a Fire endpoint and converts it into an IPS. And one of the important issues is, where does that reconciliation process belong? And I think I share your belief that it belongs on the phone. It belongs under the consumer's direct control. I say that's more important to me than on the phone, but the phone is an awfully good place for consumers to control.
Let me make one comment on that.
Please.
Just one comment, and this is, I am channeling my years at Microsoft and philanthropies and working on a world basis. Yes, in places where that exists, but we need to be inclusive in this. This has to be for all, and for all also means I may not have a smart device, and right?
Return to my statement that it needs to be under the patient's control, wherever that is.
Agree with that.
But I want to,
This mic die. So
You have to tilt your platform.
we're about to have the break announced. Come find us. I'm the tall guy in a hat. I want to show you the concept of having a non-smart device, a plastic card with a QR code, but we want that QR code, unlike Smart Health cards where it was static and you had to print a new one each time you got updated information. With Smart Health links, that information does change dynamically on the back end, and the patient could curate it and have that latest information that's relevant today, whether it's on an Apple, an Android, or a plastic card. From recycled plastic, by the way.
so let's thank the panel.